There's a lot of discussion when we had the panel discussion regarding what is the tissue, how big is the tissue. We don't get enough tissue from the peripheral lesions. We're trying to show that probably you can get big tissue even from the mediastinal nodes. So this is the thing, introduction, and how EBUS we have been doing for a long time, and how we wanted to do more. Then we started putting forceps inside, and now we're putting the cryoprobe inside the mediastinal nodes. So EBUS per se has very high diagnostic accuracy, but it's got low sensitivity in benign lesions and lymphomas. Even in malignancy, there are need for better quality of tissue for molecular studies. Like we've been enlightened in the last 3-4 hours. The number of tests that the oncologists want sort of keeps changing every month. And it's a cytology and bigger tissue improves both diagnostic confidence as well as the nuance of the diagnosis. We've been pushing. We always wanted to do what the company does not want us to do, and we've already we're using forceps. At least some of the centers were, and recently cryoprobe. So when you want to get a bigger tissue, we always were getting core out of the EBUS samples. And there have been specialized forceps which have been available in the West. We have not been party to that. And either you can put in a larger, some of our brave friends have actually done a cautery at the site of where you've gone in with the EBUS, and then pushed in the bigger transbronchial lung biopsy forceps and gotten things out. And if you want to push in the smaller needle, the thing that we get with the radial probe, forceps that can actually go into the normal EBUS entry site itself. Now, especially if you're using the 19 gauge needle, if you put in the 1.1 probe, which is quite stiff, this goes in pretty easily. So this is the forceps that have all been used in the past. So this is the forceps biopsy. If you look at it, you can see that there is a tract which you can see. You can actually see the tract which is there. And you can also see the endobronchially, there is this is the area where the EBUS has already gone in. And through that, this is the small forceps which comes with the radial biopsy forceps. You can see the forceps is inside. And sometimes, depending upon the orientation, you can actually see the forceps opening. You can see the forceps is opening. And then you will have a tug when you're trying to take the forceps out. With this, you get decent size tissue. But the only thing here is it is not always that, because the forceps is not very stiff, you'll not be able to, if you're not using a cautery to actually get through the wall, you may not be able to get the forceps in all the time. So what is the literature for forceps? If you look at it, 55 patients, it shows that there is an increase in diagnostic yield, benign condition, and may add value in molecular. It's the same thing that we started off with. There are more data, but again, like I said, Indian context, there is the official forceps is not available. And this is the meta-analysis of all the patients where the forceps was used, 467 patients. So the overall diagnostic yield of sampling, when you add the forceps biopsy, was better than EBUS TBNA alone. The complication rates were higher, but it was manageable, nothing serious. But again, this is what I was talking about. There is the Indian innovation where they've used sequential cautery. Our friend Dr. Ravi had published this thing, and he showed that in patients where it is not contributory, 27% of the patients were diagnosed by this biopsy alone. So when moving on to cryobiopsy, it is what we tend to do is we ideally attempt it immediately after the EBUS TBNA. Here, there are certain things which we do. We try and go through the same pass, each time, the single point of entry when you are taking the node. This is to try and create the tract which is easy for the cryoprobe to go in. And for this, stable wrist position is extremely important. We usually take 3 passes, but when we are going after the 4L node, we find that we probably have to take 4 passes or more because of the acute angle. And with 3 passes, especially with the 19 gauge needle, you are able to cannulate it with the 1.1 cryoprobe. we have to entirely visualize the probe before you activate the probe. The freeze time is anywhere between 3 to 6 seconds. Sometimes you go up to 8 seconds also. And of course, as with all cryo probe, you'll have to take the entire probe and the scope in total. So again, this is something that we realized over a period of time. Either, like we showed, we can actually use the ultrasound you can use the endobronchial entry point, or as we kept doing, we saw that there is what we called as a hemorrhagic line. Hemorrhagic line sometimes happens when you put in a EBUS scope, which keeps going at the same point. Other times when you don't get a hemorrhagic line, if you actually use a small saline flush, so all of a sudden this hemorrhagic line that we are able to see. When you have the hemorrhagic line, you can actually not look at the endobronchial view at all. Just by orienting your wrist so that you're able to see the hemorrhagic line, you're able to cannulate it most of the time. That's something that, so this is exactly the same. You can see that, again, I think there's some issue. The video is not running very well. This is the cryo probe here. And here there is no hemorrhagic line, but you can see that endobronchially you can make out that there is a little bit of there is a mark wherein you can actually enter, and this it's playing too slowly. All right, so all right, so it's just about the same as how you would do. It's not moving forward either. Slide's not moving forward. All right. So we were talking about biopsy specimens. So this is the biopsy that we get. I'm sure you can get most of your molecular diagnosis done with the type of biopsy that get from the mediastinal nodes. So conjugation of cryobiopsy and EBUS TBNA, it does not increase the discomfort or the risk related to the procedure. You have more informative sample collection, obtain actual histological samples, and more informative on tumor architecture. That's what our pathologist tells us, and more material for comprehensive molecular analysis than cytological samples. So if you look at the data, there was this study last year about this was multi-center study, 197 patients, and cryobiopsy had higher yield than TBNA in rare tumors, benign disorders, and this is what was there. So this is a case of 4 series that was published from Hyderabad group, which we did it for these 4 patients where they actually could not get a diagnosis. If you look at our experience, we've been doing it for the past 14 months or so. We now attempt in most patients where there is no contraindication. So we've done it in almost 55% of all the EBUSs that we have done in the past 14 months. Cryo was successful in obtaining tissue. It's very funny that sometimes you get a big tug, but you don't get a tissue. So it was successful in obtaining tissue in about 92%, 93% of the cases. And cryo and EBUS TBNA yielded the same diagnosis, exactly the same diagnosis, what the cytology yielded in about 74% of the patients. In the diagnostic yield of EBUS TBNA cytology was 89.6%. Average number of nodes sampled per patient, this was EBUS TBNA cytology, was 1.45. Number of passes per node was 3.59. EBUS cytology alone was positive. So EBUS cytology alone, where the cryobiopsy was negative in 5 patients, that was in about 7% of the cases. And of these, 2 were granulomas and 3 were malignancies. And in cryobiopsies, a total of 80 nodes and 4 masses were sampled. Average nodes per patient was about 1.09. More than 1 node was sampled in 6 patients. Average passes per node was 2.6 passes. Initially, we did 1 pass, and then we started increasing. Diagnostic yield of cryobiopsy was about 91%. Cryo alone was positive in 6 patients, which amounted to about 8% of the patients. Of the 6, 1 was lymphoma, 3 were granulomas, and 2 were malignancies. So in 9 patients, combining cryo with EBUS TBNA resulted in increased confidence while arriving at the diagnosis. Of these 7 out of the 9, cryo provided the additional information for definitive diagnosis, and in 2 out of the 9, cytology provided the same. So the combined diagnostic yield was of the cryo with EBUS TBNA was 97.4%. So what is the logic? We looked at, we tried explaining as to why cryo missed, because you're taking bigger biopsies, and this is what we came up with. So what we do is, when we do EBUS TBNA, we do what is called as fanning with our thumb. So it means that not a single point we are taking, we are able to actually take from multiple parts of the node. So if you have a tumor which is probably, or the information which is scattered around, probably you have a better chance of getting it from TBNA per se. As against cryo, no, you are able to, you can probably take from most distal and go slightly proximal, but you are not able to cover the rest of the areas. You're stuck to that one point where you're getting a bigger tissue. This is probably one of the reasons. So we use the 19 gauge needle most of the time. Use of end of view, like I said, hemorrhagic line also. It has always been 1.1. We have not yet put the 1.7 cryoprobe inside. We do all our procedures under GA, and pushing saline immediately after 19 gauge puncture actually increases the chance of getting a hemorrhagic line. Ensure that the tip of the probe is visible and is around the center. Stop if there is a lot of resistance. Like I said, we have done it in most nodes. Avoided in cases of pulp. These are the cases where we generally tend to avoid. If there is pus when we do or if you find that there is visible necrosis or Doppler showing a lot of vessels. Minor bleed can be seen sometimes. Others have reported pneumomediastinum and respiratory failure. We have not encountered yet. Cryo is easier than biopsy and probably gentler on the scopes too. And there is need for more data as well as experience. Of course, it's an interesting add-on. So EBUS TBNA has impressive yield already, and it is a tall order for any other investigation as an add-on to provide more information. Certain shortcomings of diagnosis in benign diseases and lymphoma can be addressed by this technique. In malignancy, better sample may produce further can be subjected to further tests. It has a complementary role, and ROSE is highly desirable. And can increase the bronch duration, but it also improves the yield. But for us to actually say whether it acts, you need to have multiple centers doing it, and we need to have large data coming in to see whether it actually leads to increased diagnosis, or it is just another fancy tool in our armamentarium. Thank you.
Thank you very much. Indeed, that's an interesting data. You should go ahead with publishing. There's not much in the international literature. Yes. And even I have written a paper on this with the Italians, and they are struggling with case reports on this. So this is definitely an interesting viewpoint towards cryobiopsy with EBUS.
Thank you. We have done up to 8 mm nodes also now. That's what now we started off with bigger nodes, and I think now we just get on with the EBUS so that we can go on to cryo, because
the question is that when you do cryo, you're freezing the tissue, right? Are you going to freeze the tissue that you're going to biopsy? Because
yes.
No, because I'm wondering how the pathologist feels when they see it under the microscope, because it may...
I get the point, but we've been using cryo for endobronchial lesions for a long time now. Almost the West, as in India, because cryoprobe is a sort of one-time investment, and the biopsy forceps cost each time. So the last 5, 6, 7 years, we've been using cryoprobes for endobronchial biopsy because we get a much bigger tissue. Of course, there is a risk of bleed, and the pathologists have been quite okay with that.
Thank you.
The architecture of the node or the lung, whatever you're biopsying, it doesn't change. It doesn't change.
Thank you.
You've done all the procedure of GA.
Yeah.
GA means iGel or?
iGel.
So, is there any chance of damage to the EBUS scope, because EBUS scope is not intended for this?
I understand. Yeah, that's why I'm saying till now, close to 100 procedures, it's okay. We've not had even a single dot. So that way we're okay. So we don't know. Only time will tell.
Move it together with the probe that way. That's why.
So great, thanks. Thank you very much. Thanks, that's really interesting. We now come to the last part of our discussion. And, again, it's